Assalamu alaikum. So let's start the tonight's session. So starting again with the Dr. Amir, you will be the candidate, and we will start from Dr. Noman. So you will be the examiner. So go ahead with your first
अच्छा
scenario.
अच्छा आमिर एक 35 years old lady comes to you in OPD with the complaints of a painful lump in her right breast for the last 1 month. How will you proceed?
She is a young lady with a lump that is painful in the breast. I would proceed with the triple assessment. I would obtain detailed history. I would ask about lactation, marital status, lactation, whether she is feeding the baby or not, any history of trauma.
She married 5 years ago and she has no kids.
She has no kids. So I would be asking about any history of trauma, any association with the pain with the menstrual cycle, any enlargement of the lump during the menstrual cycle, or I would take detailed history about the lump. How was it noticed, duration, onset, progression, site, size, and after, moreover, I would take detailed history about the risk factors, any family history of malignancy or any risk modifiable or non-modifiable risk factors related to malignancy. I would also take detailed history about the any signs of involvement of the skin, any ulceration, any change in color over the skin, and any signs of local or distant invasion, distant metastasis. Then I would perform examination, looking for examining her in sitting, reclining, and lying position. I would look for the symmetry of the breasts and the nipples. I would see the size of the lump and any skin or color changes. I would look for any discharge. In the history
Okay,
also, I would ask about discharge.
On examination, you find a 4 by 3 centimeter lump in lower inner quadrant of the right breast, which is hard and fixed, and you find 2 or 3 lumps in the right axilla. So how will you proceed now?
The next step would be to perform radiological assessment. After clinical evaluation, I would proceed with the radiological assessment. I would request ultrasound and mammography in this patient. Moreover, I would request core needle biopsy of the patient, and I would be interested to know the histopath, and if it is a tumor, then ER, PR, and HER2 status of the lump. And I would also request ultrasound of the axilla with FNA.
Core needle biopsy comes out that it's an invasive ductal carcinoma, and ER/PR receptors are positive. So what will be your next step?
What is the HER2 status?
HER2 status is negative.
So I would perform. I would also perform ultrasound guided FNA of the palpable lymph nodes, and I would like to see whether they are positive for malignancy as well.
Okay, then
and I would like to know whether the lymph nodes are fixed or mobile.
The lymph nodes are mobile.
Mobile. So this is T2N1 lesion clinically. Next step would be to stage the disease, and for the staging workup, I would request CT scan chest and abdomen and bone scan. Uh, Later on, I would discuss uh, I would break the bad news to the patient and discuss the patient at the multidisciplinary team meeting, uh, the tumor board, and
Okay, in MDT, MDT decides that she has to undergo surgery. What type of surgery will you offer to this patient?
since this is early breast cancer, uh, this patient can uh, be offered BCS depending upon the size of the breast. Uh, and moreover, modified radical mastectomy can also be performed in this patient. So it would
So
depend upon the
what are the advantages of and or disadvantages of breast conservation surgery in this patient?
the advantages are that the patient is young, and she would maintain the breast mount, which would have psychological advantage and cosmetic advantage. Disadvantages would be that she might have recurrence, she might have a positive resection margin, or she might have to undergo uh, multiple sessions to the chest and probably supra and infraclavicular lymph would be the disadvantage.
Okay, so you have planned a breast conservation surgery in this patient. So how will you approach the axilla in this patient? How will
Well,
you manage this patient?
the management of the axilla would depend upon the FNA results that we did, ultrasound guided FNA. If it
FNA
is positive,
FNA results are negative for tumor.
so if they are negative for tumor, then we'll perform sentinel lymph node uh, biopsy, dissection in this case. And after sentinel lymph node dissection, uh, if the results are positive, then we will go for formal axillary clearance. Otherwise, will otherwise we will just do axillary sampling and perform BCS, perform wide local XEA.
Okay, so what is axillary sampling?
So axillary sampling is uh, a technique in which around 10 lymph nodes are taken out uh, from the axilla in order to know that whether they are positive for malignancy or not.
Okay. Okay, so you have done the surgery. Post-operatively, the patient complains of altered sensations in her right arm. So what will you explain to the patient, or what will you tell her?
Well, the altered sensations can be because of intercostobrachial nerve, which was preserved during the surgery. Uh, if there is some element of neuropraxia, even if you preserve the nerve, so that causes some sort of neuralgia on the medial side of the arm. So that is likely to improve if the nerve has been preserved with conservative measures.
Okay. So the patient, you have discharged the patient and you have removed the drains. So the patient comes on 15th post-op day with a swelling in at the operation site on at the breast incision site. She has developed a swelling for the past 2-3 days, which is gradually enlarging in size. So how will you manage now?
So this patient most probably has developed a local complication in the form of hematoma or seroma. So I would check the patient's. I would perform a detailed. I would take history and perform detailed examination. I would look for any signs of abscess formation or infection of the wound, and I would request ultrasound to see the volume of the collection, and depending upon that, if the wound is okay, then I would request for ultrasound guided drainage of the collection.
Okay. So meanwhile, the histopath report comes and it confirms invasive ductal carcinoma. The margins of resection are clear, and about 5 lymph nodes are positive for the tumor. So what will be your next strategy?
So this shows that it's a high-grade tumor. It's a tumor with positive. I would also like to. I would also like to look for other prognostic factors like grade, lymphovascular invasion, and any evidence of multifocal disease or so positive lymph nodes is a single most prognostic factor. If more than 4 lymph nodes are positive, it's a bad prognostic factor. So in this case, we'll give radiotherapy to axilla as well.
Okay. चलो ठीक है यार, ठीक है शवकत. Okay, now discussion.
Yes. Thank you. Thank you, Mr. Numan. Again, Dr. Amir has responded to the scenario, the question, in a very satisfactory manner. And thank you very much, sir, for making the scenario and walking through the Amir through different situations. So I have a few observations. So obviously, I will not go into the detail. In those also which you have covered in a very, you can say, a very in a satisfactory manner. So when the examiner was asking for, you actually asked for the true-cut biopsy, and
No, I had asked for yes,
core
needle biopsy.
core needle biopsy, yeah,
Core
core
needle.
needle biopsy, and if it then it was sent for the histopathology, and it was mentioned that afterwards. So once I will see that's a tumor, then I will send for the ER, PR, and HER2 new status. So would you like to repeat this test again? So once it's a confirmed that it's a tumor.
No, I said that I would do core needle biopsy, and I would like to know ER, PR, and HER2 new status.
Okay.
Histopath and yes.
Okay. Okay. Right. Then similarly, the scenario included that there's lymph nodes are there's a axillary lymph nodes are palpable. So I think the ultrasound guided FNE, it came later on once the result of the core needle biopsy was presented.
Yes, I requested for ultrasound guided FNA at the same time.
Okay.
But examiner told later on.
Right. Right. Okay. How will you do the sentinel lymph node biopsy?
Sir, it's done by injecting. I would do sentinel lymph node biopsy by 2-dye technique. One would be technetium sulfur colloid dye, and other would be the blue dye. So sulfur colloid dye will be injected 1 day before in the office around the tumor at 3 p.m. And in the next morning, I would ask the patient to show up, and then I would inject methylene blue around the tumor. And then the patient would be taken to after 10 minutes, or the patient would be taken to fluoroscopy suite, and with the gamma camera, hot as well as blue nodes would be identified. So at the NCN would be placed in the axilla, and all the blue and hot nodes would be removed. Around 4 nodes need to be removed, and they are sent for frozen section if facility is available. If they are positive, then formal axillary dissection has to proceed. And if they are negative, then no further axillary dissection is needed.
If the facility for frozen section is available, so what would you like to do in the pre-op phase?
Regarding what?
Frozen section. If the facility for
Frozen
the frozen
section for
section is available
for
at
the-
your hospital, then
for
what?
axillary nodes?
Yeah, if the facility for the frozen section is available at your facility, at your hospital, that is available. So what would you like to do in the pre-operative phase?
Pre-operative phase, then I would talk to histopathologist
When will
so
you
that
talk to the
their
histopathologist?
services
When will you talk to
and
them?
coordinate.
When will you talk to them?
I will talk to them when I will plan this procedure so that
Okay.
their services are available once we are sending them the sample.
Okay. How much time before that, before your surgery?
A day prior.
A day prior. Yeah. So if the facility is not available, then what will you do?
Then the histopathology report, then we will wait for the histopathology report, and then we will combine excision of the tumor along with the axillary dissection together.
So you will do the axillary dissection, and if the facility for frozen section is not available at your hospital, so then you will be going for the axillary lymph node dissection, right?
No. I said that if the facility is not available, then we would combine then we will wait for the result of this histopath report, and then we would perform the surgery. We would coordinate it with the main surgery, that is the surgery for the tumor and axillary dissection if needed. We would wait for the histopath report. Once that report has arrived, if it is positive, then we would perform wide local excision plus axillary node dissection at the same time.
You are saying that you will only perform the sentinel lymph node biopsy, and you will send the specimen for the histopath. So once you receive the results, then you will go ahead the excision of the local excision, wide local excision, and then depending on the result,
yes,
you will be going for the axillary lymph node dissection if its lymph nodes are positive on the sentinel lymph, right?
Yes. Sentinel lymph node is the dissection is basically as invasive investigation in order to plan surgery.
Right.
So once the results are available, then we can plan surgery.
Right. Thank you. Dr. Usman, if you would like to ask any question.
Shwakat?
Yeah. Sir.
मेरा क्वेश्चन या कमेंट ये है कि एक्सिलरी सैंपलिंग जो है वो मेरे ख्याल में 5 to 6 lymph nodes निकालते हैं ना?
Yeah, exactly. It's
तो
axillary lymph node.
अगर आपकी 5 पॉजिटिव आ गई हैं तो क्या आप फिर फॉर्मल दोबारा डिसेक्शन एक्सिलरी डिसेक्शन नहीं करेंगे?
Okay, if you have done the axillary sampling means you have taken just few lymph nodes. So axillary dissection is level 1, level 2. So at least there should be 10 lymph nodes. So axillary lymph node dissection
5 to 10 lymph nodes.
Sampling, there's a difference. Sampling and axillary lymph node dissection. So there is a difference.
If at primary surgery only sampling was done and 5 come positive, then you have to repeat the dissection.
I think sampling is because it's sentinel lymph node. Most of the in more than 90% of the cases, you can identify the sentinel lymph node. But if you cannot identify the sentinel lymph node, I think that is the situation in which you do this axillary lymph node sampling.
Sir, इन्होंने कहा ना कि sentinel lymph node dissection available नहीं है, तो then we went for axillary sampling. क्योंकि palpable lymph nodes
मैं वही कह रहा हूँ.
हाँ, तो फिर है तो then
पॉजिटिव आती है तो दोबारा
दोबारा जाएंगे या
दोबारा सर
उसको
इसमें
रेडियो, बिकॉज यू हैव
रेडियोथेरेपी हमने दे दी ना सर उसको। वी
एक्जिला
डिड हाँ वी डिड
दोबारा हम डिसेक्शन नहीं
रेडियोथेरेपी।
करेंगे फिर?
अब इसमें भी देखें, इसमें भी जो आंसर बनता है ना उस पर यह है कि यू नीड टू कंसल्ट योर oncologist, कि व्हाट शुड बी डन. So you have performed the axillary lymph node sampling. So the 5 lymph nodes are positive. So depending on the decision, it's not only the surgeon decision.
ठीक है।
ठीक हो गया. Dr. Usman, do you want to ask any question or any comment? You are mute. Okay, let me.
If the clinically lymph nodes are present, what is the need of sentinel lymph node biopsy then? क्योंकि sentinel lymph node biopsy तो आप उसका करते हैं जब आपके पास नॉन पैल्पेबल lymph nodes होते हैं, you want to identify के sentinel lymph node है या नहीं है.
Excellent.
क्लिनिकली तो lymph node मिल रहे हैं आपको. You just need to take FNA और simple एक्सियन बायोप्सी करें उसकी, और हिस्टोपैथोलॉजी भेजें कि उसमें मेट्स हैं. क्योंकि lymph node तो दो ही कंडीशन में पॉजिटिव, या इन्फ्लेमेशन हुई हुई है या जो है ना ट्यूमर उसके अंदर मेट्स हो गए हैं. व्हेन यू हैव क्लिनिकली पैल्पेबल लिम्फ नोड्स.
नेगेटिव है।
असल में सर ने एफएनए नेगेटिव कर दिया ना, हमने एफएनए किया, वी वेंट फॉर अल्ट्रासाउंड गाइडेड एफएनए,
नेगेटिव कर दी.
तो एफएनए अब सर ने
और
नेगेटिव
दूसरी
कर दिया. अब ये है कि जब
Repeat किया जा
एफएनए
सकता है. You can
नेगेटिव कर
ask for
दिया तो
repeat.
देन
मेरा सवाल
वी हैव टू
अब
पैल्पेबल
मेरा
लिम्फ
सवाल
नोड
ये है
हैं.
कि यस, क्योंकि
हाँ,
जो मेरी अंडरस्टैंडिंग अबाउट सेंटिनल लिम्फ नोड बायोप्सी वो ये है कि इट इज द नॉन पैल्पेबल लिम्फ नोड जिसको ढूंढने की कोशिश करते हैं विद गैमा प्रोब एंड डाइंग ना. वो तो वैसे भी पैल्पेबल है, उसमें तो कोई गैमा प्रोब और इन चीजों की जरूरत नहीं है. आप लिम्फ नोड वैसे भी निकाल सकते हैं. क्योंकि सेंटिनल लिम्फ नोड तो सिंगल पहला लिम्फ नोड, सेंटिनल लिम्फ
असल
नोड
में
तो सेंटिनल लिम्फ नोड तो पहला लिम्फ नोड होता है जो कि सिंगल लिम्फ नोड होता है जो ड्रेन कर रहा होता है ट्यूमर को. ये तो इतने सारे लिम्फ नोड पहले इन्वॉल्व हैं. एंड सेकेंडली जब भी लिम्फ नोड पैल्पेबल हो जाते हैं तो ऑटोमेटिकली स्टेज तो डिजीज की चेंज हो जाती है. ठीक है.
बिल्कुल
और
इसमें ये
डिजीज डिजीज की स्टेज ही चेंज हो जाती है ना. ठीक है. और पैल्पेबल लिम्फ नोड्स में आपने उसकी एक्सिलरी क्लियरेंस करनी ही करनी है अगर एफएनए आपकी नेगेटिव भी आ गई है तो. क्योंकि लिम्फ नोड तो जो है ना पैल्पेबल है. ये तो जब पैल्पेबल लिम्फ नोड N2 हो गया ऑटोमेटिकली, या N1 हो गया. इफ इट इज मोबाइल तो
नहीं, ये
N1 है. अगर अगर
T2N1 था ना, T2N1
T2N1,
था.
जी सर, T2N1 हो गया ना.
लेकिन
तो
अब सर ने जब उसको नेगेटिव कर दिया तो फिर वो N0 बन गया ना.
नहीं सर,
यानी अगर वो
N0
कोई
सर
किसी
पैल्पेबल
भी वजह से अगर वो लिम्फ नोड किसी
पैल्पेबल
और वजह से भी
सर लिम्फ नोड या इन्फ्लेमेटरी कॉज की वजह से बढ़ सकते हैं ना. दो ही कॉजेज हो सकती हैं. या इन्फ्लेमेशन तो आप ट्यूमर में आप इन्फ्लेमेशन तो नहीं मेरा ख्याल है कर सकते हैं. नॉन टेंडर लिम्फ नोड होंगे एंड इट इज ऑलरेडी पैल्पेबल. मेरा तो ये ख्याल है कि इसमें जो है ना.
आप उसको कहते हैं
जी सर.
अगर मतलब आप एफएनए पे थे ना, इतना डिसीजन था ना, तो आप उसको कैसे रिपीट द एफएनए. इफ यू
हाँ,
स्टिल
मेरा ये ख्याल है.
भी इन्फ्लेमेटरी हो सकता है, कोई समथिंग एरर हो सकता है.
जी सर. तो 4 लिम्फ नोड्स का बहुत बड़ा फिगर जो है ना. और सेंटिनल लिम्फ नोड तो आपको एक लिम्फ नोड मिलेगा, 4 तो नहीं मिलेंगे. वो तो जो भी लिम्फ नोड एक ही होगा जो सेंटिनल लिम्फ नोड है. इट इज नॉट ऑल के लिम्फ नोड सैंपल, दे आर नॉट सेंटिनल. आपने ट्यूमर के गिर्द गिर्द इंजेक्ट किया और एक लिम्फ नोड जो है ना स्टेन होगा या गैमा प्रोब से आइडेंटिफाई हो सकता है.
नहीं, फर्स्ट 4 लिम्फ नोड आपने निकालने हैं. इसमें 4 to 5 लिम्फ नोड्स आपने निकालने हैं अगर आपने एडिक्वेट सेंटिनल लिम्फ नोड बायोप्सी करनी है. तो ये 4 लिम्फ नोड्स जो है ना वो निकलते हैं. सेंटिनल जो है दैट इज यानी बेसिकली जरूरी नहीं है कि ये जो एनलार्ज लिम्फ नोड हैं ये वही वाले हों जो शुरू वाले हों.
सर सेंटिनल लिम्फ
सेंटिनल
नोड
जो है
पहला
वो है
लिम्फ
जो
नोड होता है ना,
पहला
जो
ट्यूमर से
हाँ,
जी जो हाँ
जो
वो हो
पहला
सकता है
उसके रास्ते
कि
में.
ना हो.
हाँ,
जी
वो
जी
पहला रास्ते में आ रहा है ना.
जी
तो
जी. वो 2-3 होते हैं आमतौर पे, 2 या 3 या 4 निकाले जाते हैं, 3 to 4, और फिर उनको हिस्टोपैथ की जाती है. अदरवाइज फॉल्स नेगेटिव जो है वो स्टेजिंग के वो रेट्स निकल आते हैं कि अगर आप उसको वो करते हैं। तो ये थोड़ा सा सर ने गूगली कराई, वरना ये T2N1 था।
आपका जो फर्स्ट लिम्फ नोड होगा ना, जो फर्स्ट लिम्फ नोड बेसिकली आप करते हैं डाई देते हैं, जो एक ही लिम्फ नोड जो फर्स्ट बेसिक लिम्फ नोड का मतलब ये है कि जो ड्रेनिंग जो उसकी बेसन है उसका जो पहला लिम्फ नोड है उसको ड्रेन कर रहा है, ठीक है। तो वो आपने उसको पिक करना है, और वो उस सूरत में है कि क्लिनिकली लिम्फ नोड्स आर नॉट पैल्पेबल, अल्ट्रासाउंड पे भी नहीं है, ठीक है,
जी
नेगेटिव
सर।
है। तो उस सूरत में फिर आप जाते हैं ना इन्वेसिव डक्टल कार्सिनोमा, उसमें सेंट्रल लिम्फ नोड बायोप्सी।
जी
अगर
सर।
आपका ये है कि ट्यूमर एडवांस है, स्किन की इन्वॉल्वमेंट, इन्फ्लेमेटरी कार्सिनोमा है, ठीक है, उसमें तो सेंट्रल लिम्फ नोड बायोप्सी है ही नहीं है ना, वो
जी
तो
सर।
स्ट्रेट अवे आपकी एक्सिलरी लिम्फ नोड डिसेक्शन है।
इवन मेरा तो ख्याल है पैल्पेबल में भी आप देख लें दोबारा,
नहीं, पैल्पेबल
पैल्पेबल
नहीं,
में भी
पैल्पेबल सेंट्रल लिम्फ नोड बायोप्सी नहीं है, ये मैं कह रहा हूँ ना, कि
हाँ
अगर आपके इम्पैल्पेबल है क्लिनिकली और आपके रेडियोलॉजिकली आपने किया और उसके ऊपर भी आपको कोई फैटी हाइलम, लॉस ऑफ फैटी हाइलम नहीं नहीं आ रहा,
जी।
ठीक है, तो आपने एफएनएसी करवाते हैं उसमें नेगेटिव है, तो फिर तो आपकी वो नहीं आएगी ना। तो सेंट्रल लिम्फ नोड बायोप्सी को ये कि बेशक एक दफा दोबारा चाहिए, तो मजीद जो है ना उसको आप देख लें, व्हाट आर द इंडिकेशंस
सर।
और कंट्रा इंडिकेशन जो जब नहीं करनी, ठीक है। चलें जी, नेक्स्ट सिनेरियो।
बाकी एडवांस मैलिग्नेंसी तो उसकी कंट्राइंडिकेशन ही है वो, कि
हाँ
अगर
बिल्कुल
एडवांस है तो
बिल्कुल। सो नेक्स्ट सिनेरियो, डॉक्टर उस्मान।
सर
ओके, सो ओके, स्टार्ट अप विद योर्स।
sir, you have a 54-year-old male with chronic hepatitis C. He presents to you with pain in right hypochondrium along with generalized weight loss. He is emaciated and he has yellowish discoloration of his whole skin, and progressively he is developing jaundice. His bilirubin is raised, and he is having weight loss in almost 20% of his body during last 1 year without any change in dietary habits. He is anorexic, and there is a palpable mass in right hypochondrium. How would you proceed with this case?
This scenario most probably represents primary or secondary hepatic malignancy. I would moreover keep cholangiocarcinoma, intrahepatic cholangiocarcinoma in mind as well. So in this case, I would obtain a detailed history. I would look for the risk factors for malignancy for the liver and also in the other organs. I would be concerned about any past history of the patient, or past history of malignancy in the patient's history profile. Moreover, I would also ask about any family history of malignancies. I would ask about a history of cirrhosis, hepatitis, though he is positive. He has a positive history of hepatitis. So after all this, I would perform a thorough examination and
Okay, how would
request
you investigate?
ultrasound.
How would you investigate?
I would start with ultrasound abdomen, liver function tests, serum
Okay,
bilirubin, direct.
ultrasound abdomen reveals a 3 into 5 centimeter lesion in a caudate lobe of the liver, and it is
So
solid
next,
lesion.
yes, so it's a solid lesion. So next step would be to request triple phase CT scan,
Okay.
contrast enhanced CT scan, in order to identify whether it's hepatocellular carcinoma or
Contrast
secondary.
enhanced CT scan reveals hepatocellular carcinoma.
This is a hepatocellular carcinoma, and what's the size?
3 into 5 centimeter.
3 into 5 centimeter. And is there any involvement of portal vein or major biliary radicals or vessels?
No, there is no portal vein involvement.
So this is a liver tumor. I would stage the tumor. I would perform CT scan chest and abdomen to rule out any extrahepatic mets, any lymphadenopathy inside the abdomen, and any evidence of other malignancies in the body. I would refer this patient requires specialized center care. I would refer this patient to a hepatobiliary pancreatic surgeon who are growing these tumors in high volumes.
Okay.
After discussion.
Okay,
in
what are the
multidisciplinary
treatment
team
options
meeting.
of this tumor?
The treatment options include this is a large tumor, a single tumor. The size is around 5 by 3 centimeter. Less than 5 centimeter tumors can be resected if 1 centimeter margin is available. So a resection can be performed depending upon the status of the liver and liver function and generalized status of the patient.
Okay.
So management would depend upon these factors: functional status of the patient and the
Developing hepatocellular carcinoma, and it is involving quadrate lobe of the liver, and resection is not possible. The treatment options are left.
I would like to know whether it's child A, B, or C.
It's child A.
So abnormalities. The other treatment options would include transarterial chemoembolization plus radiofrequency ablation, local ethanol injection.
Okay,
So there are
transarterial chemoembolization was done, and patient is tumor is shrunken, and after 6 months it again reappears.
yes. Then I would again stage the tumor, and I would send the patient to a gastroenterologist in order to optimize the cirrhosis functional status, and I would refer the patient to tertiary care center for further management. Sorry, you are not audible.
Would he be requiring transplant or not?
Yes, in child A, if he is he doesn't have any cardiopulmonary ailment or other contraindication to liver transplant, yes, he can be a candidate of liver transplant.
Okay, and what are the tumor markers for liver?
Alpha fetoprotein and GGT for gamma glutamyl transferase for cholangiocarcinoma.
Okay, thank you very much, Dr. Amir. Okay, sir, house is open for discussion. Sir Shafkat.
यार मुझे एक बाकी बहुत अच्छा किया, मुझे एक क्वेरी ये बता कि कोई हिस्टोलॉजिकल डायग्नोसिस नहीं लिया बीच में कहीं?
सर इसकी जरूरत नहीं होती अभी। अभी जो है ना वो ट्राइफिजिक कंट्रास्ट सीटी स्कैन जो है दैट इज एम्पल एविडेंस टू डिफरेंशिएट बिटवीन। अब ट्यूमर लिवर ट्यूमर की जो है ना डायग्नोसिस के लिए यू डोंट नीड टू हैव बायोप्सी or just a triphasic contrast with an CT scan, it is sufficient to diagnose hepatocellular carcinoma from focal nodular hyperplasia or hepatoma or whatever, or metastatic.
जी सर, इसमें कोई अगर शक रह जाए तो फिर वो MRI with gonadolium contrast है एक साथ.
gadolinium
हाँ, gadolinium contrast वो भी साथ कर सकते हैं.
radiology is very effective, sir, in diagnosis of hepatocellular carcinoma now. So
इसमें आपने
पहले
नहीं करनी,
पहले
जरूरत
जमाने
नहीं
करते
है.
थे बायोप्सी, ट्रू कट करते थे, लेकिन अब देयर इज नो नीड एक्चुअली.
क्योंकि वो ट्रैक, नीडल ट्रैक जो है ना, उसमें वो ट्यूमर सीडिंग हो सकती है, तो इसलिए बेहतर है कि ना किया जाए.
सर शफकत, योर कमेंट्स प्लीज.
So whenever you are confronted with the liver mass, so you need to establish whether it's a solid or cystic. So if it is a solid, so the main objective in case of the liver mass is to differentiate whether it's a benign or it's a malignant. Benign with focal nodular hyperplasia or the hemangioma. So you need to differentiate them with the help of the MRI. So similarly, as Usman has already pointed out, that the radiological investigation, they are very sophisticated, and they can differentiate whether they are benign or the malignant. Now, I would like
or even
to
metastatic, even
Huh?
metastatic,
Yeah,
even metastatic.
metastatic. You mentioned that you will go for the triple phase contrast enhanced CT scan. How does the radiologist do the triple phase enhancement of the CT scan?
It's basically it's done in 3 phases.
Yeah.
In one phase, the contrast is given. First, the images are taken, and then images are taken immediately after giving the contrast. Then the next imaging is done around 1 minute after after giving the contrast, and the final phase is portal venous phase is done 10 to 15 minutes after the final contrast.
Okay. So the first phase
So this is
is
basically
not
dry
unenhanced.
physics.
The first is the plain CT. Then in the arterial phase, 20 to 30 second arterial phase. The second phase is portovenous phase. That is 60 to 80 seconds. Then is the washout phase. So that is, I think, washout phase around for the hemangioma, to differentiate for whether it's hemangioma or not. Washout phase is done, I think it's around 10 to 15 minutes. Washout phase की जाती है. तो ये timings और CT scan किस तरीके से होती है. Okay. So the first step is to differentiate whether it's a solid or cystic. If it's a solid cystic, so you need to keep in mind even the cystic masses, they can be malignant as well. So cystic degeneration of the solid masses. उसमें फिर आ जाएगा, then you need to differentiate from the hydrated cyst, simple cyst, वो आ जाएंगी चीजें. Although this was the scenario of solid में था, तो you need to differentiate with the metastatic, whether it's a mets or not. Baki, obviously, you mentioned that you will, once you have confirmed that this is the liver mass and it's a hepatocellular carcinoma, so the next step is to refer the patient to high volume center. So बाकी तो फिर वहां पे आ जाएगी. तो आई थिंक उसके बाद हमारे से रिलेटेड तो इतना ज्यादा आगे वाइवा आई डोंट थिंक हो सकता, वैसे को पूछ भी ले, लेकिन
theoretically one need to know theoretically one needs to know about the basics, that in patients with hepatocellular carcinoma or hepatitis C, what is the management plan in the hepatobiliary center, because tumor size, if it is less than 4 centimeter, you can go for
less than 5 centimeter single lesion,
yeah.
3 lesions less than 3 centimeter, they can be
resected. There is I think Milan criteria for transplant as well, that there is a tumor size and whether single focus or multifocal tumor, and because if there is single tumor, you can do the hepatectomy, segmentectomy or hepatectomy, partial hepatectomy, depending upon the location of the tumor. If it is multifocal, then answer is liver transplant. Similarly, if there is a tumor less than 4 centimeter, I think there are 3. If there are more than 3 lesions or 2 lesions, it cannot be excised. 3. It cannot be. It is an indication for liver transplant. You cannot do hepatectomy or segmentectomy of the liver. Similarly, the role of radiofrequency ablation and transarterial chemomobilization is that if you want to buy time preoperatively, you need to shrink the tumor before transplant, and or therapeutic palliative care, if it has to be given with the trans-arterial immobilization or RFA. And similar is the case with cryotherapy or I think cryotherapy as well. So this is the management.
One thing जो criteria है ना कि जो three tumors are size less than 5 जो कि आपकी resection की आप कहने के उसकी contraindications हैं कि more than 3 lesions आ गई हैं, size is more than 5.
Portal vein involved or hepatic pain involved.
Criteria. This was the previous criteria. No, it's if there's only contraindication if if it's involving the portal vein or major bile duct, right? That is a clear and contraindication for the resection. If you can resect the tumor, provided that you are retaining the functional liver, remnant liver, which is less than 25% non-cirrhotic, and it is more than 40% in case of cirrhotic, irrespective of the number of the lesions. So resection can be done. ये जो recent है.
Yeah, just 1
Because of-
centimeter margin is the
1 centimeter is a margin. You
1
need to take the
centimeter
one.
margin जो है ना, that is the requirement. If you can obtain 1 centimeter margin and the patient is fit to undergo resection,
Yeah.
and the tumor is not involving major biliary radicals or
Portal vein.
vessels, then you can go for resection.
Yeah. Or in case of transplantation, you need to exclude extrahepatic disease. That is a must. वो आपने देखना है. अब इसमें you mentioned that radio frequency ablation. So can you tell me how does this treatment modality works? Radio frequency. How do
Sir,
they do it?
I think it's a radiation-based treatment in which a needle is passed into the tumor and then energy is delivered.
So it's a radiation. Radiation.
Yes,
No, it's ultrasound.
it's
Ultrasound. No. It's ultrasound based
No.
modality.
No. So he has given the answer, partly corrected answer, right answer. It is basically it's a locally the tumors is heated up to 80 degrees centigrade. Okay, it's a heat. So for long period of time, for example 60 minutes 1 hour जो टाइम है बेसिकली आप पहले से उसको करते क्या है उसका सीटी के ऊपर सिमुलेशन पे देखते हैं कहाँ पे ट्यूमर के उसी पैसेज नीडल पाथ कहाँ से नीडल जाएगी, नीडल वहां पे डाल देते हैं उस ट्यूमर के अंदर और फिर उसके बाद उसको हीट करते हैं. इट्स जस्ट लाइक समझे डायथर्मी है, तो वो हीट करती 80 डिग्री सेंटीग्रेड और प्रोलॉन्ग कॉन्टेक्ट टाइम होता है, प्रोलॉन्ग होता है उसका, तो उससे फिर क्या होता है ट्यूमर जो ना सारा वो मेल्ट होता है. रेडियो फ्रीक्वेंसी एब्लेशन.
रेडियो फ्रीक्वेंसी.
हाँ, रेडियो फ्रीक्वेंसी एब्लेशन. ठीक है, इट्स बेसिकली हीट है, लोकल हीट है जो प्रोवाइड की जाती है वहीं पे ट्यूमर, तो उससे फिर एब्लेशन होती है. ठीक है सर नुमान, आपकी तरफ से कोई क्वेश्चन, कोई कमेंट?
नहीं बस ठीक है, आगे चल.
अच्छा चलें जी, नेक्स्ट है जी, कर लेते हैं हम लास्ट सिनेरियो.
सर
Okay, a 25-year female patient has been reported in the emergency department with the history of abdominal pain, fever, and bloody diarrhea. So the internal medicines they have reviewed this patient. They have asked for the GS consultation because of abdominal pain. Now, how will you evaluate this patient?
This is a young patient with abdominal pain, fever, and bloody diarrhea.
Yeah.
So I would take detailed history and perform a thorough examination. In the
What will you
history, I
ask?
would be
Yeah.
interested to know that whether this patient had previous history of any loose motions and diarrhea.
Yes,
is she passing blood?
Yes, she has the previous history. She has been having the episodes of the bloody diarrhea in the past. Her last episode was 10 months back.
Sorry, there was a distortion in the voice.
I'm saying that this patient, yes, there is a past history of bloody diarrhea. So her last episode of the bloody diarrhea was about 10 months ago.
So only a single episode.
She's having a repeated episode, but last episode was 10 months back.
And is she under treatment for loose motions and similar complaints?
Yes, she has been taking the treatment.
Continuously?
Yes, she has been taking the treatment off and on.
Off and on. So not as a continuous feature.
No.
So in this patient, most likely I would be concerned about acute exacerbation of inflammatory bowel disease. However, I would keep infective colitis, gastroenteritis, and other pathologies like ischemic bowel in mind as well. I would like to know her daily motions, the number of motions she is passing daily. I would like to know that.
Passing stools
What is-
around 7 to 8 episodes of the 7 to 8 episodes
of
bloody
bloody
diarrhea.
diarrhea per day.
Yeah, bloody diarrhea.
And is there any mucus in the stools or not?
Yeah. With mucus.
So this patient is having significant diarrhea with bleeding. She requires a resuscitation. I would be evaluating, discussing with internal medicine colleagues about her previous medications, treatment history, and her courses of relapses and remissions. I would request gastroenterologist to step in as perform colonoscopy in this patient. I would also rehydrate her, give her IV antibiotics, and in consultation with the IM colleagues, I would.
The gastroenterologist has reviewed the patient and he's saying that it is acute phase. So the colonoscopy he is worried that this patient can end up with perforation because it's acute phase. So your gastroenterologist he has expressed his concerns over the colonoscopy. What will you do?
Then I would request contrast enhanced CT scan in order to see with triple contrast
CT scan. Which contrast will you administer? IV, oral?
I would go for triple contrast enhanced CT scan with oral, IV, and rectal contrast.
Oral, IV, and rectal. Why do you want to give the rectal contrast in this patient?
Because I would like to know that whether the rectum is involved, whether large colon is involved, and whether it's a continuous involvement or they are skip lesions. So the oral contrast will give me delineate for me
the CT scan,
small bowel.
CT scan will reveal the colon wall is thickened. There is fat standing in the mesentery as well. And
the colon
what else do you want?
What else
would you like to ask the radiologist? Any other information?
Yeah, any evidence of mucosal ulceration, any crypt abscesses, or any string sign on the in the ileum, any thickening of mesentery of the ileum?
Ileum is fine. He's saying ileum is fine.
And what's the exact part of the colon that is thickened?
It's the whole of the colon, starting from the cecum. It's cecum, ascending, transverse colon, sigmoid colon, up to the sigmoid.
And the rectum is not involved.
He has not. Rectum is He is doubtful.
He is doubtful. So most probably this patient has ulcerative colitis, and she has come with acute exacerbation. I would be also interested to know that whether what's the size of the colon, what is the diameter of the colon, and what's the cecal diameter, and is there any evidence of contrast extravasation or not?
There is no contrast extravasation, so the diameter of the colon is 5 centimeter.
5 centimeter. So the patient needs admission in high dependency unit, and she must be monitored serially.
How will you
She needs
monitor?
serial.
How will you monitor her?
I would monitor her by continuous monitoring of vital signs. I would perform abdominal evaluation 4 hourly. I would also perform X-ray spine
Okay. So
for evaluation.
what would you looking for in the X-rays?
I would be looking for any distension of the colon,
Okay.
because this is an acute exacerbation. She
Okay.
might go into
here is an
toxic
X-ray.
megacolon.
So here is X-ray. Can you see my slide? Slide. Can you see the slide?
Yes, yes.
Okay, here is our X-rays. What will be your next step?
So it's a distended, grossly distended colon.
Okay.
It doesn't look like 2.5 centimeter.
No,
It
not
looks
2.5.
like,
I just actually 5 centimeter on the CT scan. Initially 5 centimeter, and during the monitoring, you asked the X-rays. So this was the next day. This was the X-ray.
And what's the diameter given by the radiologist?
No, the diameter is it's 5.5 centimeter.
5 by 5 centimeter.
Okay. Now, what will your next step?
So I would discuss this X-ray with the radiologist.
Okay.
In this X-ray, I am suspicious of about volvulus as well.
Okay. So why are you thinking volvulus?
Pardon?
Why are you thinking volvulus in this patient?
Because the distended loop is going up in the left hypochondrium.
Okay. Okay. No, you have discussed with your radiologist. You went to the radiologist, and he's saying that just look at here. Here, what is this? And this shadow. What is this? Can you appreciate this one? These shadows. Here, here.
Yes, there is some hypodense area in the lower part.
And what it could be?
In the rectum.
The rectum. So she is a 25-year female patient. What it could be?
Well, I'm not sure. I would discuss it with
Or
the
say the radiologist
radiologist.
told you that this is the fetus.
So this is the fetus.
Yeah, here's the head. This is the fetus head, and this is the belly. Now, what will you do? So this lady is pregnant.
So this lady is pregnant. That would not change the management, except for the drugs that are contraindicated in pregnancy that will not be given.
Okay. Okay.
So I would
during the monitoring, your nursing paramedical staff has told you that the patient discussion is increasing, and the pulse is initially it was at 90, now it's 110 per minute.
So in this case, the patient is deteriorating. The clinical signs are indicating that she is likely to go. She is likely to. Uh, s- she is having some impending perforation. Since she is pregnant, I would also involve gynecologist and obstetrician in this case, and I would go for exploration.
Okay. So, so what would you like to do in the while doing your preparation? What would be doing? Anything?
While preparation, I would
Mm.
see that blood is available. I would
Okay.
correct all the. I would correct the hypotension so that there are no. There is no morbidity to the mother or the fetus. Moreover, I will arrange the blood. I would arrange for continuous fetal monitoring during the
So,
operation.
okay, you gynecologist, she has done the cesarean. No, what will you do for this acute fulminant colitis?
For this, I would perform subtotal colectomy and ileostomy.
And ileostomy. So, okay, fine. So after the subtotal colectomy and ileostomy, what will you do during the follow-up phase? So the patient has recovered well. She has been discharged.
Later on, if if she has good sphincter function,
Yeah.
then we can go for ileoanal pouch anastomosis.
Ileoanal pouch anastomosis, that means you will be resecting her rectum. Hello.
Yes.
Okay. So you will perform the ileoanal anastomosis in this patient, the completion proctocolectomy with ileoanal anastomosis in this patient.
Ileoanal pouch anastomosis, yes.
Would you like to review her histopathology?
Yes.
Okay, it's a Crohn's disease. Histopathology reveals a Crohn's disease.
So then simple ileorectal anastomosis can be performed because
Okay, if suppose it's a ulcerative colitis, then what will you do?
so if it is ulcerative colitis, then we would go for proctectomy and ileoanal pouch anastomosis.
So anything
Once
you
the
would like
patient
to,
is out.
would you like to inform the patient about anything before going for the completion proctocolectomy?
Yes, she might. I would inform her about all the complications related to proctectomy. That it might include sexual dysfunction, uh, uh, complications related to pouch, that is pouchitis, increased stool frequency, and other related complications.
Okay, okay, right.
Like bleeding,
Thank you.
infection.
Thank you. Now, house is open for the discussion. G. Amir, starting from, sir, if you want to ask any question.
ठीक है अच्छा अच्छा उसने डिफेंड किया और अच्छा केस था तो
ठीक है
ठीक है
उस्मान
सर इसमें मेरा ये था कि थोड़ा सा मेडिकल ट्रीटमेंट को टच नहीं किया इन्होंने बिल्कुल भी।
नहीं वो तो उन्होंने डाल दिया ना कि मेडिकल ट्रीटमेंट पे वो डाल दी मेडिकल
फेल हो चुके, फेल हो गए।
इन्वॉल्व द मेडिकल स्पेशलिस्ट इन्वॉल्व द गैस्ट्रोएंटरोलॉजिस्ट और
but with conservative measures it's everything failed and ultimately she landed up in total proctocolectomy. माइक ये एक खातून, शी इज ए लेडी, what sexual dysfunction she can have, because it's not related to females, that sexual dysfunction. uh, in the case of proctocolectomy, I don't think so. It is more
तो मैंने
related to the
हिंट
males.
भी दिया था, हिंट भी दे रहा था बार बार ना, जो बेसिक
है
मैं हिंट भी दे रहा था. आई वाज गिविंग हिम हिंट. व्हाट इज द मोस्ट एज? शी इज अ 25-year lady. What is the
Well,
most
in
important thing?
females,
हाँ,
in females also, these nerves are responsible for maintaining the sexual function, like secretions and other
but the
things.
most important thing, infertility. Infertility.
Yes,
Patient
yes,
patient can, there's a
sexual
high chance
function.
of infertility. That is the most important. The
Yes.
patient may not opt for this IUI approach. So she would like to complete her family first. She may live with this ileostomy, and later on, once her family is complete, then she will opt for this IUI procedure, because there is a high chance of infertility because of the adherence, increased risk of hydrosalpinx, जो बन जाती है उसकी वजह से. So that is the most important. So this decision needs to be made where keeping in mind the patient's preferences as well. So इसमें के most important है counseling. Timing of surgery उस पर करेंगे जब उसकी काउंसलिंग करेंगे और ऑब्वियसली पेशेंट रिकवर कर, फिर उसके मुताबिक आप उसकी करेंगे. ठीक है. और जी,
ठीक होगा सर. और इसमें सर ये एक्सरे फीटस के साथ शील्ड करके क्यों नहीं कराया गया?
वो तो आपने कराना था ना. देखिए, अब मैंने क्या, ये बेसिकली आपको ना, मैंने एक केस रिपोर्ट का उसके ऊपर ये सारा मेरा सिनेरियो बेस्ड अपॉन अ केस रिपोर्ट. इट्स नॉट, वैसे नहीं मैंने बनाया हुआ था. ठीक है. To begin with, this is a young lady, or most of the time inflammatory bowel disease, peak incidence of disease in the age of childbearing age, उसी टाइम फ्रेम में होती है ना, ये डिजीज भी उसी में होती है. और आपने इस फीमेल पेशेंट आ गई तो प्रेगनेंसी का लाजमी पूछना. ये बेसिकली थोड़ा मैंने किया कि ये किसी भी सिनेरियो में है कि whenever there's a childbearing age, तो आपने प्रेगनेंसी का पूछना है. इसमें तो वैसे भी डिस्टेंडेड होगी एब्डोमेन, मतलब आपके टॉक्सिक मेगाकोलन है तो एब्डोमेन विल बी डिस्टेंडेड. So you will not be knowing is it because of the pregnancy, it could be first trimester, second trimester pregnancy हो सकती है, जो अर्ली उसको कहेंगे, और उसके साथ टॉक्सिक मेगाकोलन हुआ. ठीक है. तो एक आपको ऑब्वियसली आपको थोड़ा जब सरप्राइज मिला होगा कि ये तो फीटस आ गया, तो आप याद रहेगा नेक्स्ट टाइम के प्रेगनेंसी का जरूर पूछना है. So you started off very well. You asked me the questions. So what's the duration? Is there any past history of similar complaints? So that means you all these questions led you to in the right direction. So you are in the right direction. You were thinking about the different differential diagnosis of the acute fulminant colitis, for example, infective colitis, ulcerative colitis, Crohn's. So you are on the right track. You involve the internal medicine, gastroenterologist, and you started off with the medical treatment. One thing was, so I asking the colonoscopy in acute phase, that is the contraindication. Acute phase में नहीं करवाते. So then I gave you the hint that your gastroenterologist worried. He has expressed his concern that in the acute phase there is a possibility of perforation. ये पहले मैं दिया. फिर again going with the CT scan with IV and oral and rectal contrast. Rectal contrast देंगे. I don't think so कि rectal contrast का है इसमें, किसी को मैंने पढ़ा नहीं है कि rectal contrast वो दें. वही बात है कि acute phase के अंदर कोई भी rectal contrast या अनीमा शीमा नहीं देते, वो फ्लेयर अप होता है ज्यादा, स्पेशली जब आप सस्पेक्ट करें कि यार परफोरेट ना कर दें, तो कंट्रास्ट देंगे तो परफोरेट कर सकते हैं. वैसे सीटी कराएंगे, दैट इज सीटी स्कैन हैज रिप्लेस्ड द, जो इवन इलेक्टिव फेज के अंदर भी, इलेक्टिव सेटिंग के अंदर भी जो करवाते होते पहले एनीमास करवाते थे ना, तो आपने क्यूट में करा ली, सीटी करवा लिया, लेकिन सीटी कराने से पहले इट्स रेडिएशन. सो इट्स अ फीमेल पेशेंट. तो ऑलवेज जो आपको चेक लिस्ट नहीं मिलती जब सीटी स्कैन हमने कराना होता है, तो उससे पहले होती चीजें, जो चेक लिस्ट, कंसेंट भी साइन कराना फलाना, वो भी इनकॉर्पोरेट दोज थिंग. अगर वो किए तो उदी आपको पता चल जाता कि ये प्रेगनेंसी है इस पेशेंट की. फिर देन यू मॉनिटर द पेशेंट विद एक्सरेज. आपने कहा कि आई विल स्टार्ट अप विद द मॉनिटरिंग, जो सारा उसके पूरा प्रोटोकॉल.
अब ये जिस तरह अगर ये प्रेग्नेंट है तो एमआरआई करा सकते हैं इसका सीटी की जगह पे?
एमआरआई क्यों कराएंगे? एमआरआई में क्या
नहीं
बताएंगे? देखिए नो, अब इसमें हमने करना क्या. सो यू हैव एस्टैब्लिश द डायग्नोसिस, नॉन केस ऑफ अल्सर. हम पूछते हैं कि इसकी पहले कोई बायोप्सी हुई है, आप और क्वेश्चन क्या पूछ सकते थे? यू कैन आस्क कि इसकी कोई इन्वेस्टिगेशन हुई है, इज देयर एनी कोलोनोस्कोपी इस पेशेंट की हुई है कि नहीं, कोई बायोप्सी हुई भी है. अगर हुई तो आपको डायग्नोसिस में बताता है ये इसका डायग्नोसिस है, इसकी बायोप्सी भी हुई थी पहले, ठीक है। और फिर आप क्लियर कट हो जाता है इट्स एक्यूट फुलमिनेंट कोलाइटिस विद द पॉसिबिलिटी टॉक्सिक मेगाकोलन, ठीक। तो अब क्लियर कट, अब उसमें करना है कि सिंपल अपने एक्सरे कराना है, सो जस्ट टू सी द साइज ऑफ द कोलन, इफ इट्स मोर देन 6 सेंटीमीटर दैट इज एन इंडिकेशन फॉर द अर्जेंट सर्जरी। और अगेन बाकी उसके पल्स इज इंक्रीजिंग, abdominal डिस्टेंशन, टेंडरनेस, ये जो पेशेंट डिटेरियोरेट करना शुरू कर देता है डिस्पाइट द मेडिकल ट्रीटमेंट, ठीक है। तो उसमें आपने इमीडिएट आप उसकी सर्जरी करनी है। तो अब उसमें भी जॉइंट डिसीजन है बेसिकली बिटवीन द सर्जन एंड द गैस्ट्रोएंटरोलॉजिस्ट। तो अब अगेन वही आपने जाना तो उसी तरह जैसे ये,
अगर सर उसकी नहीं हुई हुई पहले जो है क्लोनोस्कोपी भी नहीं हुई, बायोप्सी भी नहीं हुई हुई,
हाँ यस
फिर आप कैसे
यस,
उसको डायग्नोज
फिर
करेंगे?
फिर आपने क्या करना है, फिर टेक इट, इट कुड बी अ क्रोन्स, इट कुड बी अल्सरेटिव कोलाइटिस, बोथ थिंग्स हो सकते हैं। तो आप उसमें क्या करना है, एक्यूट सेटिंग में इट्स सब कोलेक्टोमी विद आइलियोटोमी, सब टोटल कोलेक्टोमी, जिसमें रेक्टम को प्रिजर्व करेंगे, ठीक है।
नहीं, पहले डायग्नोसिस कैसे करेंगे? बेरियम एनीमा
नो 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 नो
कराएंगे, क्या करेंगे?
नो नो, बेरियम एनीमा कंट्राइंडिकेटेड, एक्यूट फेज में इस कंट्राइंडिकेट, सिर्फ आपने यू नीड टू रूल आउट कि ये कहीं वो इन्फेक्टिव कॉज तो नहीं है, स्टूल आपने भिजवा दिया, उसके कल्चर के लिए भिजवा दिए, ट्रोफोसाइट के लिए भी जो देख लिए, टॉक्सिन उसके देखे कि एंटीबायोटिक पे तो नहीं था कि ये पेशेंट जो क्लोस्ट्रीडियम डिफिसाइल वाले जो सूडोमेम्ब्रेनस कोलाइटिस वाला, ठीक है, उन चीजों को आपने रूल आउट कर दिया। और पेशेंट एक ये भी हो सकता है सडनली पहला ही एपिसोड आप टॉक्सिक मेगाकोलन को हो, आल्दो मैंने पढ़ा तो नहीं है, लेकिन इट्स वेरी रेयर कि फर्स्ट एपिसोड ही टॉक्सिक मेगाकोलन का हो। और वैसे भी टॉक्सिक मेगाकोलन की जो इंसिडेंस है ना, ये वैसे कम है बिकॉज ऑफ द जो मेडिकल ट्रीटमेंट स्टीरॉइड्स हैं, आपकी एजाथायोप्रीन और बाकी जो मोनोक्लोनल एंटीबॉडी ना इन्फ्लिक्सिमैब, इसकी वजह से टॉक्सिक मेगाकोलन की इंसिडेंस कम है। तो इसमें जो डायग्नोसिस है ना वो क्लोनोस्कोपी एक्यूट सेटिंग में नहीं करनी, इट्स कंट्राइंडिकेटेड। और एक्सरेज है बेसिकली सीरियल एक्सरेज, साइज उसमें दो, साइज इसका 6 सेंटीमीटर है। और गिल्वी सिंड्रोम में है जिसमें उसका सीकम का अपने डायमीटर जो है ना वो है 12 सेंटीमीटर है ना, 11
जी सर,
11
10 भी लिखा
11,
हुआ है, 12 भी लिखा हुआ है।
हाँ
तो 10 10 to 12 है
10 12
बेसिकली। अगर 10
वो,
से ज्यादा है तो फिर
हाँ,
आपने उसकी
और गिल्वी, तो ये चीजें हैं जो इसको आपने उसको रखनी है अपने माइंड में ना। तो बाकी
फिर
कोई,
आपने उसका
हाँ
फिर आपने उसका कुछ करना है अगर 10 से ज्यादा है तो।
हाँ बिल्कुल, वो उसमें गिल्वी में है, तो इसमें 6 सेंटीमीटर है। तो आई थिंक so on all of the scenario, today your performance was excellent.
सर थैंक यू
तो
वेरी मच।
होपफुली हाँ, नहीं नहीं आज
लेकिन
आपको
इसमें
बहुत
ये
अच्छा,
है कि आप हमेशा थोड़ा सा जो है वो डिफरेंट
मुश्किल
लेके आते हैं।
मुश्किल लेके आता हूँ हर दफा जो ना
डिफरेंट लेके आते हैं तो थोड़ा सा हट के।
हाँ
और
थोड़ा सा
ये
ना
है कि
नहीं
आप अपना रिकॉर्ड जो है ना वो मेंटेन कर रहे हैं।
है ना फिर उसके बाद तुम
ये
शुरू
नहीं
होते
है
ये
कि
ओगलवी का जो
हाँ
तूने
दो
डॉक्टर
तीन के बाद
हाँ
वो होता है ना कि बंदा दो
ये
तीन के बाद कहता है कि अब रूटीन में आ जाओ बस।
हाँ, नहीं नहीं गुड, वेरी गुड। आज आपने
बाकी
परफॉर्मेंस,
माशाल्लाह
हाँ
तैयारी बड़ी अच्छी है।
हाँ, नहीं नहीं जबरदस्त, माशाल्लाह तुम्हारी अच्छी, बहुत अच्छी तैयारी है। और इंशाल्लाह निकल जाएगा।
इंशाल्लाह सर, अल्लाह
शौकत, ये
ताला खैर
ओगलवी का
करे।
जो रूल बताया,
हाँ सॉरी,
ये ओगलवी का जो तूने रूल बताया, ये सिग्मोइड कोलोन के लिए है।
नो 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 नो, इट्स फॉर द सीकम। गिल्बी सिंड्रोम बेसिकली क्या है, उसमें आपके इसी तरह पेशेंट आएगा एब्डोमिनल डिस्टेंशन का, पेन चेन इतनी नहीं होती गिल्बी में, एब्डोमिनल मैसिव एब्डोमिनल डिस्टेंशन के साथ है पेशेंट ना, और विद कॉन्स्टिपेशन। तो उसमें आपने लार्ज बॉल ऑब्स्ट्रक्शन की सारी साइन सिम्टम्स होगी, आपने बेसिकली यू नीड टू डिफरेंशिएट विद दिस मैकेनिकल ऑब्स्ट्रक्शन और इट्स सूडो ऑब्स्ट्रक्शन। तो उसमें आपने कंट्रास्ट करवाना है, कंट्रास्ट जो आप कराएंगे, एनीमा करवाएंगे, सीटी स्कैन कराएंगे। जब वंस यू हैव एस्टैब्लिश दैट देयर इज नो ऑब्स्ट्रक्शन, मतलब मैकेनिकल ऑब्स्ट्रक्शन, कोई स्ट्रक्चर नहीं है, कोई मैस नहीं है, फिर उसमें क्या करना है, सीरियल उसके साथ आपने देखना है कि सीकल डायमीटर के, बिकॉज सीकम इज द, आप कहने कि उसके लैप्लास रूल जो है ना, कि उसकी जो वॉल की जो थिकनेस कम होती है, तो यहाँ पे जब एक्सपैंड, सबसे एक्सपेंशन इसकी सीकम एक्सपैंड करती है कोलन के पूरे पार्ट में से, और सीकम इज एट रिस्क ऑफ परफोरेशन। तो सीकम का बेसिकली आप उसको मॉनिटर कर देंगे, 10 सेंटीमीटर से ज्यादा हो तो आपकी इंडिकेशन बन जाती है, फिर उसकी इसको सिकोस्टमी
सर ये
करेंगे।
दोबारा बताएंगे जरा, मैं सर ये दोबारा बताएंगे जरा, मैं डिस्कनेक्ट हो गया था।
सर ने पूछा था गिल्बी सिंड्रोम का, तो मैंने कहा गिल्वी सिंड्रोम के प्रेजेंटेशन इज बेसिकली जस्ट लाइक साइन symptoms of large bowel obstruction. So whenever you are suspecting a large bowel obstruction, you need to differentiate whether it's a mechanical obstruction or it's a functional obstruction, pseudo obstruction, with the help of the contrast and CT scan, triple contrast then with the rectal contrast. So once you have established that there is no mechanical obstruction, now the next step is to there is series of the intervention जो आपने करनी step wise approach आपकी starting from your आपने देखना है कि you need to quit your medication जो narcotics तो नहीं ले रहा patient, right? You to review the drug history. Electrolyte, you need to correct the electrolyte imbalances. वो आपने किया. Rectal tube, colonoscopy, ठीक है? वो से आपने किया, नहीं ठीक हो रहा, फिर उसके बाद क्या करेंगे? आपके neostigmine. Meanwhile आप उसको monitor करते हैं cecal diameter को. If it's that cecal diameter is increasing, that means there is a chance of impending perforation. Cecal diameter से 10 centimeters ज्यादा होता है, indication अगर आपकी सर्जरी को उसके आधा. अदरवाइज क्या होगा, फिर वो परफोरेट करेगी. तो हमने पहले भी किया था डिस्कशन इसके गिल्वी पे भी ना.
हाँ जी.
एक
नहीं सर, वो
सिनेरियो.
गिल्वी पे अपने डिस्कशन किया है.
हाँ बिल्कुल.
तो इसमें सर्जरी में इसमें करेंगे क्या? सर्जरी में इसमें
क्या
सर्जरी
सर?
में करेंगे क्या?
सर्जरी, हाँ सर, उसमें स्टेप वाइज चलते गए ना. स्टेप वाइज इनिशियली मेडिकल मैनेजमेंट आपने सारी कर ली, वो हो गया. क्लोनोस्कोपी के लिए डिकम्प्रेशन कराई, रेक्टल उसको क्लोनोस्कोपी के लिए ट्यूब आपने डाल दी, ठीक है. साथ उसी पॉलीथायरीन ग्लाइकोल के अनीमा भी देते रहे, वो करते रहे. अच्छा, फिर भी पेशेंट रिस्पॉन्ड नहीं कर, फिर आईवी न्यूस्टिग्मिन देते हैं आईसीयू सेटिंग. आपने एक डोज दी, रिपीट, यू कैन रिपीट इट अगेन. अच्छा, फिर भी नहीं चल रहा, ठीक है ना. फिर उसमें आते आप उसकी ट्यूब सिकोस्टमी की एक इंडिकेशन है, किसी भी वक्त अगर परफोरेट कर गई है तो फिर उसमें सब टोटल कोलेक्टमी है विद आइलियोस्टमी.
अब परफोरेट कर गई है, फिर ये है कि अगर उससे भी नहीं इंप्रूव करती नियोस्टिग्मिन वगैरह के साथ, तो फिर आप एक इसका लूप निकाल सकते हैं.
हाँ, लूप निकाल सिकोस्टमी कर सकते हैं, वो कर सकते हैं.
और उसमें फिर ये है कि उसमें आप यू कैन वॉश फ्रॉम द सिकोस्टमी. उसमें कैथेटर बेस्ड वॉश करके तो उसको आप जो है उसकी जो वो है फ्लो उसको वो कर सकते हैं रेगुलेट के लिए बेहतर हो जाए. और फिर ये है कि वही जैसे अगर कॉम्प्लिकेशन हो जाए या नहीं चल रहा तो फिर सब टोटल कोलेक्टमी और एलियोस्टमी है आखिर में.
बिल्कुल.
जनरली ये एल्डरली लोग होते हैं जो कि ये
दिल की तकलीफ वाले, गुर्दे फेल हुए हुए,
आईसीयू वगैरह में,
पार्किंसनिज्म वाले, बेड रिडन,
न्यूरोलॉजिकल एलिमेंट्स वगैरह वाले, बिल्कुल ऐसे ही है.
तो
ठीक हो गया.
एनी अदर क्वेश्चन, फिर खत्म करें फिर.
जी सर.
सो थैंक यू वेरी मच फॉर
थैंक यू सर.
joining and sharing.
Thank you sir, thank you very much.
Thank you so much. Thank you so much.
ओके सर. आमिर.
Thank you sir, thank you.